Thank you, Jim, and welcome to Las Vegas, everybody. I guess what happens in Las Vegas stays in Las Vegas outside of this room, but inside the room, you're welcome to take it all home, and that's what I hope you do. I'll be talking about ER-positive breast cancer, as you heard, and these were the questions I was tasked with addressing: neoadjuvant and adjuvant therapy and the role of hormonal therapy, how I sequence hormonal agents in advanced disease, mechanisms of resistance, and managing premenopausal ER-positive breast cancer. And I've chosen to address it in this order. First, looking at adjuvant and neoadjuvant therapy in pre- and postmenopausal patients, sequencing of agents in pre- and postmenopausal patients, and then mechanisms of resistance. So first, looking at adjuvant therapy, premenopausal. And I think just to start with the conclusion, tamoxifen remains a standard of care. This ATLAS trial indicates that 10 years of tamoxifen is better than 5, and it's really in this premenopausal group where I think this is most relevant, although as we'll see, it does raise a lot of questions about what we ought to do with postmenopausal patients as well. And actually the ATLAS data I'm going to present later during the postmenopausal talk in the context of other extended adjuvant therapy. So our approach to this problem is informed by a number of clinical trials. This is an old trial done by the U.S. Intergroup in ECOG looking at ER-positive, node-positive premenopausal breast cancer. And this was at a time when the role of tamoxifen was not as clear as it is now. And patients were randomized to FAC chemotherapy, or FAC chemotherapy followed by gaserelin, or FAC chemotherapy followed by the combination of gaserelin and tamoxifen. What is missing here is what we consider the standard of care, which is tamoxifen for 5 years. So this trial really did not directly address the situation we're faced every day, but it did raise some interesting questions. The bottom line, in terms of disease-free survival, the addition of gaserelin to CAF chemotherapy did not add anything overall. But tamoxifen did add to CAF plus gaserelin. So there was a clear benefit to adding tamoxifen. But this trial was confounded by chemotherapy-induced menopause or ovarian suppression. And in a subgroup analysis, patients who were younger, age less than 40, or who had premenopausal estradiol levels after chemotherapy, and patients who continued to have menses with chemotherapy seemed to benefit from gaserelin. So it did raise the possibility that there was a role for ovarian suppression in that group, but it did not address the question of tamoxifen alone or whether gaserelin actually added to tamoxifen. So the U.S. Intergroup and ECOG tried to address this issue in node-negative patients who were node-negative ER-positive, who received at that time no chemotherapy, randomized to get tamoxifen or tamoxifen plus ovarian suppression. Unfortunately, this was a failure in terms of accrual. The goal was almost 1,200 patients, and only 345 women were randomized, so the trial was closed early. The 5-year disease-free survival, as you could guess, was not significantly different. But there were significant differences in the two groups, and the significant differences were that there's more toxicity with the addition of ovarian suppression. So in terms of menopausal symptoms and sexual function, as you might expect, there was a downside to ovarian suppression. So I do think it's an important question to address, and this is, in fact, has been addressed in this trial, the SOFT trial, the results of which we're still awaiting. So patients who, this got around some of the problems we've had with other trials. This was addressed to patients who either did not get chemotherapy or who remained or recovered ovarian function after chemotherapy. They were randomized to tamoxifen, ovarian functional suppression plus tamoxifen, or, since aromatase inhibitors seem better than tamoxifen in postmenopausal patients, if you make a patient postmenopausal, is an aromatase inhibitor better? And that question is being addressed in the third arm of ovarian functional suppression plus exemestane. And I think going into this, all of us thought that third arm would be a slam dunk, but I just remind you that the evidence we have does not support that. There was this ABCSG trial in which premenopausal node-negative patients received no chemotherapy but got tamoxifen or with gaserelin or ovarian functional suppression or ovarian functional suppression plus an aromatase inhibitor, and there was no difference, and so no advantage to an aromatase inhibitor in addition to ovarian functional suppression as compared to tamoxifen in these premenopausal patients. So this question remains relevant. Now, postmenopausal patients are a larger group, of course, and I first want to remind you who benefits from hormonal therapy, and it's the ER-positive patients, which seems kind of old hat, but I think it's worth remembering. This is information from the meta-analysis. So you can see the ER-positive patients on the top clearly benefit. The ER-positive, PR-negative patients benefit from hormonal therapy, and it looks as if progesterone receptor is primarily a prognostic marker, and the estrogen receptor is primarily a predictive marker for response to endocrine therapy. This small group of ER-negative, PR-positive patients does seem to get a benefit from hormonal therapy, but it's modest, and the ER-negative, PR-negative patients get no benefit from tamoxifen. So I think this is just worth bearing in mind. Aromatase inhibitors are the cornerstone of treatment in postmenopausal patients. It can be sequenced in a variety of ways, any of which are considered acceptable. I think most commonly, patients are just getting aromatase inhibitors off the bat. And this is the results of a meta-analysis of this approach, looking at a tamoxifen versus an aromatase inhibitor, either letrozole or anastrozole. And you can see with continued follow-up, there's a continuing benefit in terms of relapse-free survival, but only in the few percent range, 3-4% range, and still no statistically significant survival advantage. There are some differences in distant relapse-free survival, which might translate into survival advantages, but I think we just have to keep in mind the survival advantage has yet to be proven, and it appears to be minimal so far. An important trial, I think, is this one from Big 198, which indicates that the aromatase inhibitor up front did make a significant difference. But as we know, many patients have difficulty tolerating this medicine. Sometimes we switch to a different aromatase inhibitor. Sometimes that's successful. But an important bit of information to keep in mind is this trial. One of the arms of Big 198 looked at patients treated with letrozole up front, so randomized to letrozole for 5 years, or randomized to switch to tamoxifen after 2 years. And as you can see, there is no difference in these two arms. So at least so far, it looks like if a patient is having significant toxicity from an aromatase inhibitor, simply cannot tolerate this class of drugs, switching to tamoxifen seems to be safe based on information so far. Now, what about the duration of therapy? And this is an important question, brings up this issue of extended adjuvant therapy with tamoxifen or an aromatase inhibitor. This slide shows the hazard rate, sort of the slope of the recurrence curves for ER-negative and ER-positive patients put on a sequence of adjuvant trials from the Eastern Cooperative Group. And as you can see, in the ER-negative patients, you get this early bump in recurrences, but then later on in the course of therapy, the rate of recurrences declines. In the ER-positive patients, you don't get this front loading. There is a little bump early on where the chemotherapy seems to be helpful, but after somewhere 3 to 4 years, these curves actually cross, and it's in this ER-positive patient group that you get this persistent pressure for recurrences 5-10 years after diagnosis. And it's because of this risk in observation that something like half of recurrences in this group of patients occur after 5 years. Extended adjuvant therapy regimens have been looked at. The one most familiar to us, I think, is MA17, in which patients who were postmenopausal, they could have been premenopausal at diagnosis, but who were postmenopausal after around 5 years of tamoxifen were randomized to placebo or letrozole, and you can see there was a significant advantage in terms of relapse-free survival in patients receiving letrozole. So because of this, this has become a very standard practice for many of our patients. The new news is this ATLAS trial, which has been going on for a number of years, which looks at extending tamoxifen for an additional 5 years after 5 years of tamoxifen. And of course, this issue has been looked at before. There was the NSABP trial, which is the one best known in this country, looked at patients completing 5 years of tamoxifen, randomized them to 5 additional years or placebo. And this trial was actually stopped early, the results released in a futility analysis, because as you can see here, the patients getting placebo actually were doing better than the patients getting tamoxifen. And even there was a trend in terms of overall survival, although this was an early analysis. And because of this, and we forget that this was a futility analysis, the standard of care became 5 years. There was sort of a biologic rationale that was advanced, and because of this, 5 years was considered optimal. Now, the Atlas trial then didn't, basically these investigators wanted to look at this issue again, and they were also informed by additional information from the meta-analysis. And this shows the effects of 5 years of tamoxifen on recurrence rate. And what you can see during the first 5 years, looking at the control placebo patients on the top and the tamoxifen patients on the bottom, these curves spread apart. After 5 years, the drug is stopped, and interestingly, there still is some divergence of the curves. They are not yet parallel. So the recurrence rates in the patients who received tamoxifen during the first 5 years continues to be lower even after the drug is stopped. This is the so-called carryover effect. And it's only after you get to around 9 or 10 years that these curves start to become parallel. So this is perhaps an explanation for why this earlier trial was negative, that there was this carryover effect from the tamoxifen that sort of hid any benefit from continuing tamoxifen, because the patients who took tamoxifen for 5 years were still seeing some benefit, even though they had stopped the drug. So that served to attenuate the differences in the two groups, at least with an early analysis, which is what you get with when you stop or analyze the trial early. So the Atlas trial looked at 10 years versus 5 years. And the bottom line here is recurrence and breast cancer mortality was affected, but not so much during these early years, years 5 to 9, but primarily after year 10. And these are the data from the Lancet publication showing patients who stopped tamoxifen in red and those who continued it here in blue. There was a late difference in overall survival. Now, this trial was a large, simple trial. We don't have a lot of information on these patients. It was largely done in first world, in part in first world countries, but it was a large trial, and I think I believe the data. How this compares to aromatase inhibitors, we really can't say at this point in terms of data. Looking at kind of hypothesized differences of 10 years of tamoxifen versus none, this shows the gains here on the bottom, weighed against the possible toxic or fatal side effects of tamoxifen, and you can see that it comes out in favor of taking tamoxifen, something like 0.2% mortality rate during 5 and then additional 10 years of treatment with tamoxifen, so that the calculation comes out in favor of taking tamoxifen. But this trial, of course, raises a number of questions as we practice medicine. I'm sure many of you have gotten phone calls from your patients, and unfortunately, I can't always help you answer these because they're just questions we don't know. Can the results of MA17 and Atlas trial be applied to patients receiving initial therapy with aromatase inhibitors? I think this is an important question. So after all, we give aromatase inhibitors for 5 years because we gave tamoxifen for 5 years. If now the standard of care is to give tamoxifen for 10 years, or if we had had this information to start with, we probably would have used aromatase inhibitors for 10 years. Recurrences after 5 years of therapy continue to occur, and we have a number of trials showing that we can affect the recurrence rate, either with tamoxifen or with aromatase inhibitors. It so happens these trials were done in patients who took tamoxifen for 5 years, but the biologic question is the same. So why should patients treated with aromatase inhibitors be different? And so I think many of us in high-risk patients will give patients extended adjuvant therapy after 5 years of aromatase inhibitors, but we have to understand that we really don't have any direct data on this. Fortunately, this question has been addressed, and we await the answers to it. But there are a lot of questions. And if patients are treated with an aromatase inhibitor, could they take another 5 years of an aromatase inhibitor? Could they take another 5 years of tamoxifen? And as I said, we just have to wait for some data. We might go outside the data in particularly high-risk patients with an informed patient. Now, in advanced disease, I'm again going to talk about premenopausal and then postmenopausal breast cancer. And in a premenopausal patient, of course, the primary source of estrogen is from the ovary, and oophorectomy was performed in 1896 by Bateson, and there's some references to prior to that time. Nowadays, there's still a role for oophorectomy, but of course we have tamoxifen and GnRH agonists, so a medical approach to ovarian functional suppression. So how do we use these? To my mind, the standard treatment in someone with metastatic ER-positive premenopausal breast cancer is with a combination of ovarian functional suppression and tamoxifen. We don't have a lot of level 1 data on this. This is a small trial from Europe in which patients were randomized to tamoxifen, ovarian functional suppression, or both, and there was an overall progression-free survival, as you see here, but this was a very small trial, as you can see, something like 100 patients per arm, so really a small trial. There was actually a survival advantage, though, and because of this, to my mind, this is the standard of care. In first-line metastatic patients, ovarian functional suppression plus an aromatase inhibitor works, but I don't think we have level 1 data to say it's better than using tamoxifen with ovarian functional suppression. And the bottom line is, in terms of sequencing treatment patients, in second, third line treatment, you're going to want your patient to be postmenopausal. So I think it makes sense to use ovarian functional suppression up front with tamoxifen, where there's a suggestion of a survival advantage, and you're going to want the patient postmenopausal thereafter for subsequent manipulations. So we need to ensure ovarian suppression. In postmenopausal patients, aromatase inhibitors are used commonly. It gets a little bit more difficult in patients now that we're using aromatase inhibitors in the adjuvant setting. Just to kind of march through the trials, as aromatase inhibitors have moved up and up, aromatase inhibitors appear equivalent or superior to megestrol acetate in second-line setting. They're equivalent or superior to tamoxifen as first-line treatment, and I think are the treatment of choice as therapy in metastatic hormone receptor positive patients, in patients who have not been previously treated with aromatase inhibitors, and there are insufficient data to definitively recommend one aromatase inhibitor over another. They've all been compared to other comparators, seem a little bit better, but it's hard to find any reason to pick one over another in terms of efficacy. This just shows one such trial. This is looking at fulvestrant, and tamoxifen can be used as a second-line regimen if the patient has had prior aromatase inhibitor, or fulvestrant. Here you see fulvestrant, in this case, compared to anastrozole, patients as first-line treatment. In this trial, using a dose of fulvestrant of 250 milligrams IM monthly, it was essentially equivalent. Similar data were found with tamoxifen, which is a little puzzling. But although those trials in that era were somewhat compromised because of estrogen receptor determination, was not done in all patients. Now we use a dose of fulvestrant of 500 milligrams, and it's based on these trials, which I'll show you here. So this is a randomized phase 2 trial looking at fulvestrant versus anastrozole, and here the fulvestrant was 500 milligrams IM every 2 weeks for 3 doses, and then monthly. Is a small trial, as you see here, but there was a significant advantage in terms of time to progression for the high-dose regimen as compared to anastrozole, as it compared to rough equivalents for the lower dose of fulvestrant. The confirmed trial was recently updated. This is a phase 3 trial looking at 2 doses of fulvestrant, the 250 milligram dose or the 500 milligram dose, again with a loading course, and then monthly. And you can see there were 736 patients, so a phase 3 trial. And here you can see an advantage for the higher dose in terms of progression-free survival. And in terms of overall survival, there was a trend because of issues noted or understandable primarily by statisticians. This p-value is not considered to be significant, but there is some suggestion of actual survival advantage for patients getting the higher dose of fulvestrant as compared to the lower one. So fulvestrant, I think, is a good drug for in patients who've had prior anastrozole. It's at least as effective as anastrozole, and the 500 milligram dose seems to maybe the most active single endocrine agent. So I think it's reasonable to use either before or after an aromatase inhibitor. A question, should we use it with an aromatase inhibitor? This question was addressed most recently by this SWOG study published in New England Journal, SO226. The background, I think, is known to many of you, but anastrozole lowers estrogen levels, fulvestrant downregulates the estrogen receptor. This combination was used in preclinical models and appeared promising. So SWOG launched this trial. Now, this trial was done at a time when the aromatase inhibitors were kind of just, or the patients treated with adjuvant aromatase inhibitors were just kind of coming on board, so that the patient population actually is a little bit different than you might expect. Initially, prior adjuvant tamoxifen was allowed. It required a protocol amendment to allow prior adjuvant aromatase inhibitor therapy, but it turns out very few of these patients actually received adjuvant aromatase inhibitors, and something like a third, some 30% of patients apparently were frontline patients presenting with metastatic disease. Regardless, here's a randomization, anastrozole alone or anastrozole plus fulvestrant. Here the dose of the fulvestrant was a kind of a semi-load, 500 milligrams, 250 at 2 weeks, 250 at 4 weeks, and then monthly thereafter. And here are the results, progression-free survival, thank you. And there was an advantage, which was statistically significant for the combination over single-agent anastrozole. Looking at in whom the advantage was seen, you can see the patients taking prior tamoxifen had a relatively, had no significant advantage. The majority of the benefits seemed to be in those patients who had not received prior tamoxifen, which apparently means these were patients presenting with metastatic disease. And in terms of survival, there actually was an overall survival advantage, which is interesting. It's hard to get in breast cancer. Again, the patients who had had prior tamoxifen were not seeing this advantage. The majority of the patients benefiting were those who had had no prior tamoxifen. So this is an interesting trial. There's some provisos. This subgroup analysis was not planned, so we need to see if there's some other supporting evidence. You may recall there was another trial looking at this combination that was dead negative. There was no advantage to the combination. So we have to ask ourselves, why is this? Was it just, different trials got different results due to randomness, or is there something different about the patient populations? And I think it's the latter. So if we're going to use this combination, in whom should we use it? If we're going to use it, I would think it's be in this hormone treatment naive group of patients. But then what dose of fulvestrant should we use? Because this trial used a dose of fulvestrant which is not commonly used. So if we're going to use it, I would use 500 milligrams, although that's not what was done in this trial. So now, just very quickly, I'm going to race through some mechanisms of resistance and how to address them. The number one mechanism of resistance is that patients don't take the drugs. This is adherence in the ATLAS trial. You can see 16% of patients at 2 years were not taking the drug, and close to 30-40% of patients after 5 years are going to be off the drug. So that lack of adherence is a very important issue, and it needs to be looked at and addressed. And we're really not doing anything until we make sure our patients are taking their oral medications. Another approach that hasn't worked is adding bevacizumab. This is a trial that was presented at San Antonio recently, in which patients took letrozole or fulvestrant with or without bevacizumab, and there was no significant difference in progression-free survival, and not even a hint of a difference in overall survival. So this approach doesn't seem to be useful. What I think has gotten the most interest is looking at this interaction of estrogen receptor and signaling through the AKT mTOR pathway. There's this crosstalk that all of us have read about. There's some preclinical evidence that that activation of this PI3 kinase pathway can predict resistance to hormonal therapy. And so this trial was done. This is the TAMRAD trial, which looked at patients previously refractory to aromatase inhibitors, randomized to get tamoxifen or tamoxifen plus everolimus, and there was an advantage in terms of progression-free survival and even overall survival in this small trial, randomized phase 2 trial. Interestingly, looking at the total study, here's the hazard ratio 0.53, patients who had primary hormone resistance, in other words, progressed right out of the box on aromatase inhibitors, seemed to have minimal benefit the major benefit was those who developed what's called secondary hormone resistance, who seemed to benefit from treatment and then subsequently developed resistance. And that group in this trial is the one that seemed to benefit the most. So this phase 3 trial was done, exemestane with or without everolimus, in patients refractory to letrozole or anastrozole, and the results are known to you here, published in New England Journal. You can see there's both locally and centrally an advantage for patients receiving the drug in terms of progression-free survival. All subgroups seem to benefit, and there was an advantage in terms of response rate. So that there is a clear advantage to this approach. Overall survival data are not really available yet. There is additional toxicity, not only monetary, but also stomatitis, rash, fatigue, and this pneumonitis that is occasionally seen, as well as hypoglycemia. So this is the summary of the results, which you can have on your devices. But the real question is, will there be a survival benefit, and is this benefit worth the cost? So I think this is the issue that we will be dealing with. I'm going to stop there. I have some more slides, but I think I'll just stop there for the sake of time. So thank you.
Okay, so wait.
Okay.
We have a bunch of questions.